Hello, everyone, and welcome to today's niche webinar, Oral Health Dementia. I would like to introduce our speakers for today. First, we have Judith Haber, Associate Dean for Graduate Programs and the Ursula Springer Leadership Professor in Nursing. She's also the Executive Director of Oral Health Nursing Education and Practice Program. We have Pam Stein, the University of Kentucky College of Dentistry. She's also the Associate Dean for Academic Affairs. Next up, we have Rita A. Jablowski-Jodin, the UAB Associate and SOM Professor. Lastly, we have Elaine J. Amella of the College of Nursing, Medical University of South Carolina. So with no further ado, I'd like to hand the floor over to our presenters. If you're ready, the floor is all yours.
Hello, everybody. This is Judy Haber, and I'm going to give you a little background about oral health and dementia, starting with the Surgeon General's report and the IOM reports in 2011, which called for a greater role for nurses and other professionals within the context of oral health. And, you know, nurses provide care for many vulnerable persons, particularly frail and older adults. And these people are the least likely to receive the necessary health-sustaining oral health care, which is so important to their overall well-being. Healthy People 2020 list oral health as one of the top 10 leading health topics, which is something that is known by very few people. But it is a national problem and is particularly acute among the elderly for whom there is a scarcity of dental benefits. So we like to say that older adults' oral health is often in a state of decay. We all know about the growing number of older adults in the U.S., and because dental care is not included in the Medicare benefit, most won't have access to dental care. 70% of older adults do not have access to dental care. And the most vulnerable of these people are the approximately 5.2 million older adults who have dementia, which is the focus of our webinar today. But some of the barriers to accessing affordable dental care, because even when we have healthy elder adults, as I said, there is limited income and often coverage for a dental benefit. There is not necessarily the understanding, either in the well elderly or those with dementia, about the need for routine dental care, and a significant percentage of older adults don't regularly visit the dentist. Some of it is because of lack of ability to pay for dental services, and also we know that even though dental services may be there, they may not be accessible to older adults who have difficulty traveling, especially those who are vulnerable, frail, and have dementia. So some of the problems that can occur for older adults in relation to linking oral health, poor oral health, and their overall health is the significant number of older adults who lose their teeth, which leads to nutritional deficiencies, the percentage whose poor oral health leads to infection, gum disease, and severe systemic diseases such as ventilator-acquired pneumonia. 50% have untreated cavities, which can lead to pain and infection. And then the largest number of people with oral cancer are in the older age group, which of course has a high mortality rate in and of itself. So the recent publication of the IPEC competencies in 2011 has challenged all of us to engage in interprofessional, patient-centered care around meeting the oral health needs of older adults. And today we're focused, as I said, on a particularly vulnerable population, the older adult with dementia. The HRSA report, released in 2014, identifies the interprofessional oral health competencies that primary care providers and other health professionals, that is physicians, nurses, nurse practitioners, clinical nurse specialists, physician assistants, can contribute to meeting the oral health needs of this vulnerable population. At NYU, we have transformed the HEENT exam, head, ears, eyes, nose, and throat, to the HENOT exam, so that you cannot forget about oral health when you are either taking a health history, completing a physical exam, preparing a risk assessment, or an action plan that is largely health promotion in nature, but also involves collaboration and referral with our dental colleagues. There are many resources for you to avail yourselves of in order to learn more about oral health in older adults with dementia. The Smiles for Life curriculum, Module 8 to be specific, which is about oral health and older adults, provides a wealth of information for you to learn about the oral health needs of older people in general, but specifically as well about older adults with dementia. Additionally, our ONEP website for the Oral Health Nursing Education and Practice Program also provides a wealth of resources for you about meeting the oral health needs of older adults, including those with dementia. So we hope you will check out both of those resources to help you in more effectively meeting the needs of this vulnerable population. We've listed a number of references and links for you to consider and to go to increase your knowledge base and clinical competencies around improving the oral health of people with dementia. So now I'd like to turn the webinar presentation over to my colleague, Dr. Pam Stein, who will continue.
Hello, and thank you for joining us for our webinar today. I'd like to talk a little bit about three main objectives. The first is describing what we can expect normally to occur in terms of aging changes in the oral cavity. Secondly, to describe some oral changes that we might expect in individuals who have dementia, some cognitive deficits. And third, to discuss what the law requires related to provision of oral care in long-term care facilities where many individuals reside who have dementia. So the first thing I'd like to talk about are just some normal changes that occur with aging in the tooth structure itself. We all have some cracks in our teeth, and we get those as we age. The older you are, the more cracks or craze lines you have, and the more apparent those become as we have some staining that gets into those cracks and craze lines, and also as they become more definitive and deeper. Teeth also appear darker as we age. The enamel loses some translucency, and the enamel becomes worn a bit. It gets a little thinner, and the underlying dentin, which is more yellow in color, shines through and makes the teeth look a bit more yellow. So that's to be expected as we age, as well as a certain amount of wear. So in the picture that we have of wear on the slide, you can see there is some wear there. Now, wear can be excessive, and that would be considered an abnormal change, but some wearing of the chewing or the biting surfaces of the teeth is expected as we age. In addition, there are some changes that occur normally in the oral mucosa, or the lining of the mouth. This includes changes like thinning of the mucosa and loss of elasticity. This makes the mucosa more susceptible to injury and abrasion. And there's also a decrease in the number of immune cells in the oral mucosa, and this creates a problem with healing sometimes. A little bit of a delay is expected in healing of tissue. So all of this calls for more gentle handling of tissue when we are caring for older adults or when they are caring for themselves. I wanted to talk a little bit about normal changes in salivary glands. This is one of the biggest problems that we see as dentists in terms of abnormal changes is changes with the salivary flow, but really the changes that occur normally, even though there are some, including loss of the number of cells in salivary glands and a decrease in the number of salivary glands, these do not typically result in a decrease in the actual amount of salivary flow. So we have three pairs of major salivary glands, the parotid glands, which are in front of the ears, the submandibular glands, which are under the mandible, and then the sublingual glands, which are under the tongue. And in all three of those pairs, we have a loss in the number of cells as we age, and we also have a decrease in the number of minor salivary glands, which are interspersed throughout the oral mucosa. You can see in the picture on the slide, if we pull our lower lip down, we'll see some little bumps. It's almost kind of like a cobblestone appearance. And those are all minor salivary glands. Those are also on the insides of our cheeks and on the palate, and we have a net loss of those minor salivary glands as we age. But typically none of these changes really result in a noticeable change in the amount of saliva that we produce as we age. Now, this is in contrast to a person who has dementia. So now I'd like to start talking about objective number 2, which is changes that are not normal aging changes in the mouth, but instead are changes that we might expect in someone who has dementia. And in this case, on this slide, we're talking about salivary gland changes in those who have Alzheimer's disease. So research has shown that there is a decrease in salivary flow in those who have Alzheimer's disease, but we still don't know the mechanism for that change. We also know that there are certain medications that people who have Alzheimer's disease or other dementia may be taking that exacerbate drying effects of the mouth. On this slide, on the top, we can see the tongue, and the tongue has some lines through it. This is called a fissured tongue, and this is really a hallmark of a dry mouth. So if you have a patient or if you're caring for a person who has a tongue that looks like this is a sign of a dry mouth, and it really is a cause for an intervention. I'll talk a little bit more about what can be done and what happens if there are no interventions in patients who have dry mouths. The picture below the tongue is a picture of someone who has some sores and cracks in the corner of the mouth. And this is also another hallmark of someone who has a really dry mouth. Sometimes these cracks will become infected with yeast and get some candida. And so this is another, a patient or someone that you care about has something that looks like this, these cracks in the corner of the mouth. This should be a sign to you that they have dry mouth and this needs attention. The effects of dry mouth can be devastating, regardless of the cause. One of the biggest problems we see with dry mouth is tooth decay. So the saliva provides buffering. It decreases the amount of acid in our mouth, and it also just mechanically kind of washes off the teeth. It's very important. It's a very important part in preventing decay in our mouth. And so when we don't have enough saliva, we see more decay. And in older adults, we see more decay on the roots. And you can see that in the photos on this slide. In fact, you can see some teeth. The one front tooth is actually completely broken off because the decay was so bad it just decayed the tooth in two. So when an individual has a dry mouth, one of the things that can be done to prevent the decay is to prescribe fluoride, which can be prescribed in a rinse or a toothpaste or a gel. Sometimes, though, with swallowing deficits, and I think that's going to be talked about a little bit later in the webinar, it's not appropriate for any of those types of fluoride to be sent home with a patient with dementia. And so a professional can do something like a fluoride varnish. Nurses can apply fluoride varnish, and physicians and dentists and hygienists as well. So that's an alternative to the toothpaste and the mouthwashes that are prescription strength. In addition, other things that we worry about when a patient has dry mouth, things like inability to really taste food very well, so loss of appetite, or problems wearing prosthesis like dentures and partials. The saliva really helps to create suction to keep those prostheses in place. In addition, a person with a dry mouth typically has discomfort. Sometimes their tongue will burn, or they'll have mucositis, and so it's a quality of life issue as well as a health issue. Other oral health concerns in patients with dementia are related to psychomotor deficits that are related to changes happening in the brain. In addition, memory changes really can be disastrous. So patients may not be able to remember to perform oral hygiene, or they may not remember how to perform oral hygiene. And so the typical pattern that we see in the dental profession is that in early dementia, we may see a patient that looks something like what we have on the left, where we see patients who clearly have spent a lot of time and money and effort and energy on maintaining their teeth. This on the left, you can see there's some really nice dental work in there, and this person, you really don't see any plaque. They're keeping their teeth very clean. But unfortunately, we often see a progressive deterioration of the oral status to something like what we see on the right, where as the patient loses their cognitive abilities and their functional abilities, they're just not able to provide the daily oral hygiene that they need, may not be able to get in and see a dentist, and their oral health deteriorates pretty significantly. I've put some of the activities of daily living on this slide. This is some impairments that are typically seen in residents in long-term care facilities. About 50% of the patients in long-term care facilities do have some type of dementia. And if you look at this list and the percentage of residents in long-term care that have difficulty with these ADLs, you can imagine that something that requires even more fine tactile skill like brushing and flossing would certainly be a problem. So even though oral hygiene is not listed as an activity of daily living, we can imagine that that would suffer if we look at this list as well. So some other other factors that lead to poor oral health in patients with dementia include the fact that many of the frail elders are staying in the community longer prior to going to a nursing home or long-term care. They may have limited access to community dentists. Their caregivers may have trouble getting them in. They may arrive on admission at long-term care with neglected dentition. And once they arrive at a long-term care facility, the priority given to oral care may be low because there are so many other health issues. Research has shown that there is a good deal of unmet dental need in long-term care, and even though I don't have it on the slide, we also know that for elders who are living in the community but are homebound and frail and with dementia, that they really have the highest percentage of unmet dental needs of any cohort in the older adult community. So compared to community-dwelling elders that are healthy, elders who are in long-term care or who are homebound and frail, they have much greater a much greater percentage of unmet dental need. And I thought it was worth mentioning that oral pain presents in a very different way in patients with dementia. So typically when a person who does not have dementia has a problem in the mouth with a tooth or a mucosal sore, they may complain of sensitivity to hot and cold, that it might linger. They may say they have a severe toothache, a throbbing pain, and they may have a headache. This is not what we see at all in a patient who has dementia. Typically, if they have a problem with a tooth, they will exhibit things like worsening of behavior, acting out. They may refuse to eat. They may refuse to cooperate in other ways. Increased restlessness. Maybe they're not able to sleep. Moaning or shouting for no apparent reason. So if you have a person that you're caring for and they exhibit some of these signs and symptoms, it's worth taking a look in their mouth and doing an assessment to see if maybe there's something in their mouth that is leading to these problems. Now I want to address objective number 3, which is the federal mandate to provide care in long-term care institutions for dental needs. In 1987, the Omnibus Budget Reconciliation Act, known as OBRA, passed. This was mandated to improve the standard of care in nursing homes, not just the standard of care for oral issues, but really the standard of care in general. But it did require facilities to actively provide or obtain dental care for their residents. So what this means is that long-term care facilities have to either provide a dentist in the facility to provide care, or they have to have an agreement with a dentist off-site to provide dental care for their residents. Now, not all facilities have to comply with this, only those facilities who receive federal monies. So those facilities that accept Medicaid or Medicare have to comply with this OBRA mandate, and that really does cover many of the long-term care facilities. Most of them do, except Medicaid or Medicare. So to go over the specific guidelines of the oral health requirements that OBRA mandates, long-term care facilities must meet the routine and emergency dental needs of each resident. They must assist in making appointments and providing transportation to and from the dentist, and they must promptly refer any resident who has a problem with a denture to the dentist. Oral health issues are starting to really get a lot of attention in the press and among the lay community. This is just a little excerpt from a New York Times article that was published about a year ago that describes several cases throughout the country where there are some unattended to dental problems. So the public is becoming more and more aware that this is a mandate, that it's a law, and they are asking and demanding that long-term care institutions and dentists as well, dental professionals, really step up and take care of the needs of the residents. In addition to the mandate to provide professional dental care, nursing facilities are also responsible for ensuring daily oral hygiene as part of just the care of the resident, the overall personal hygiene needs. So just like making sure the patient or the resident has a shower and their nails clipped and their hair brushed, long-term care facilities are also responsible for making sure residents have their teeth brushed on a daily basis. However, some studies have shown that maybe not all long-term care facilities are able to do this. In fact, a study in 2006 showed that only about 16% of nursing home residents were receiving any oral care, and that the toothbrushing time was pretty short, about 16 seconds, and it should be 2 minutes. That's the standard of care. And in this particular study, the nursing assistants weren't wearing clean gloves to provide oral care. So this paper was really a call to action. And it also makes us think about why this might be. Why is it that help with daily oral hygiene is a problem in nursing homes, long-term care facilities? And there's been some research and some literature that describes some of the problems, including there are just other priorities. There are time constraints. Most of the daily oral hygiene care is provided by nursing assistants, and they have many other things to do. There may be a lack of perceived need by the patients, family administrators, and the nursing staff. They may not understand, as Dr. Haber explained previously, that there is a connection between having poor oral health and other general health issues, and there's a quality of life issue there and comfort issue as well. Some nursing assistants may just not care to do the daily oral hygiene care because it's kind of off-putting to them. And then I think probably one of the biggest problems is, in general, there's a lack of knowledge about how to care provide oral care for those who resist care. And in patients who have dementia, this really is a big issue. That most patients who have dementia don't want someone coming towards their mouth to brush their teeth, and they're often resistant to that. So there are some really good resources to help those caregivers who want to try to provide this care in a gentle, effective, and non-threatening way. And one of those resources is our next speaker, Dr. Jablonski, who is really a leader in this area nationally in terms of providing strategies and providing research on the best ways to provide care when patients resist oral care. So now I'll just turn the floor over to Dr. Jablonski.
Thank you, Dr. Stein. I'm Rita Jablonski-Judon, and I'm going to follow up with ways to provide mouth care to persons who may reject oral hygiene. One of the concerns we have in long-term care, you really want to respect the autonomy of nursing home residents. However, people with dementia are not always exercising autonomy when they refuse mouth care. At times it is a knee-jerk response to a perceived threat. So first I want to put in the disclaimer, this work is brought to you by NIH, NINR, your tax dollars at work, and my presentation does not represent the official views of any of these entities. So at this point, what are care-resistant behaviors? They're also called care rejection if you look in the minimum data set version 3.0. And it really is any action that thwarts or evades care during a caregiving interaction. It is the context and not necessarily the behavior that differentiates care rejection from agitation. So where does the care rejection come from? Well, we use a theoretical framework of the neurobiology of threat perception, which is a mouthful. Essentially, we as humans are hardwired to perceive threat and respond with fear to certain images and situations. Evolutionarily, the most common things that will engender threat perception are snakes, spiders, and heights. And when you think about it, it is a protective mechanism because snakes and spiders were often and are often poisonous, and heights could present a problem to early man. Currently, the amygdala is emerging as the center of the threat perception universe. The amygdala stores and moderates memories of threats. And you can see it in the slide there, the little red dot in the center of the brain. When a threat is perceived, the fear response is activated through the amygdala and then through other tissues in the brain, resulting in the autonomic component, which is the elevated heart rate and the sweating, as well as the behavioral components that we know as freeze, flee, or fight. Usually, other parts of the brain, specifically the cortical pathways, the thalamus, hypothalamus, and hippocampus, interact with the amygdala to contextualize whether an image or situation is really a true threat. And those parts of the brain will provide feedback to the amygdala saying, no, this is not a true threat, and then the fear response is stopped. The problem with an individual with dementia, the atrophy of these pathways, as well as atrophy of the other structures, results in a disruption of the feedback mechanisms. So a person with dementia may not really be equipped to determine if something is a legitimate threat. Therefore, persons with dementia tend to approach the world in a state of heightened threat perception. Everything is perceived as a threat, even if it really isn't. And if you can wrap your head, no pun intended, around that, the neurobiology of threat perception, that then makes sense why mouth care often engenders the rejection of care. Because as Dr. Stein pointed out, we are literally getting into people's face. We are going into the airway. We are approaching them from a vulnerable place. So I'm going to talk about some strategies that we use in our research, and these strategies are starting to become disseminated, and we are finding that they do minimize the perception of the mouth care provider as a threat to the person with dementia. And these approaches are rather simplistic, but they're easy to do. It's always interesting when you talk about your research to your parents. And I was home over the holidays, and I was talking about my research to my mom, and she said to me, "Well, hon, this is common sense." However, even though these techniques are deceptively simple, you can really make a difference with them. The first is to modify one's approach. And we can modify our approach by approaching the older adult in a non-hurried manner, approaching at or below eye level, and smiling. It's also a good idea to use the environment to provide cues to support the activity, and this is known as priming. Mouth care, therefore, should always be done in front of a sink and preferably in a bathroom and not while the person is sitting on a commode, which is what often happens in a lot of long-term care facilities. Finally, caregivers really need to avoid the use of elder speak. Elder speak is a type of sing-song cadence which involves high-pitched tone of voice, the use of diminutives such as honey or dear, and plural pronouns such as, "Are we ready to brush our teeth?" Unless you have a toothbrush in your hand and you are brushing your teeth with the older adult, that type of approach is not appropriate. Dr. Christine Williams has published extensively on elder speak serving as a trigger to care-resistant behavior in persons with dementia with things like bathing and dressing. And we can see the same issue in long-term care and even outside of the community. The take-home message here is persons with dementia may forget their name, they may forget great chunks about their previous lives, but they never, ever, ever forget that they are adults. And elder speak is really an assault or an attack onto their personhood. Other gestures that are very helpful other strategies that are very helpful are gestures and pantomime, usually accompanied by short, respectful one-step sentences, and they go a long way in preventing and reducing care-resistant behavior. With chaining, the caregiver begins a mouth care activity and encourages the older adult to complete it. Another piece to remember is when possible, it is best to encourage the older adult with dementia to perform as much mouth care as possible. If their hands are going into their mouths, it's not as scary as your hands. Again, mouth care can be seen as a double assault because we get very close and almost invasive. Having a person with dementia perform his or her own mouth care does mitigate the perception of assault and threat. Distraction is a commonly used technique, and it includes talking, singing, massage, and even the use of objects. I have the cat there because in one of the nursing homes where we did our study, Snickers the cat would follow us around when we did mouth care. We found out later Snickers liked the taste of the toothpaste, but with one resident in particular, she would pet the cat and allow us to provide mouth care. Even singing is a rather popular, and it sounds almost contradictory, but we've had individuals who were very resistant to mouth care, but as soon as you began to sing, even with the toothbrush in their mouth, they would hum or sing along. Other techniques are talking to the elder about activities or hobbies such as playing the piano or golf, talking to the older adult about important people in his or her life such as grandchildren, and pets also may distract the elder from mouth care and reduce care-resistant behavior. Bridging, a technique I'm going to talk about in a moment, can also work as a distraction. That is, if the elder needs you to brush his or her teeth and starts resisting, you have the option to give the older adult a toothbrush to hold while you then brush his or her teeth. And as You see in the picture, bridging involves giving the older adult a related caregiving object while providing mouth care. It can be a toothbrush, it could be a denture cup. If the person has an old pair of dentures, you can even use that. And what happens is when the older adult holds a toothbrush, the toothbrush can serve as a memory aid and release proximal memories surrounding mouth care, again, reducing threat perception and the resulting care-resistant behaviors. Hand over hand is a technique that can be accomplished one of two ways. One way is to have the caregiver put his or her hand over that of the elder and encourage the elder to engage in mouth care activities by gently moving the elder's hand and leading them through the mouth care activities. Another way is to have the older adult put his or her hand on the caregiver's hand and follow while the caregiver is providing mouth care or removing dentures. For elders who may be very, very passive and just won't open up their mouths, providing mouth care in front of a mirror may also help, and we discovered this by accident. What happened, I was showing one of my mouth care providers how to do mouth care, and the bathroom was really, really tight. So I stood behind the resident and placed the resident in front of the mirror to allow the mouth care provider to also see what I was doing in the mirror. And as soon as the older adult looked into the mirror, she smiled and opened up her mouth and let us do mouth care, and that became a daily strategy. So it is tricky, but if you can wheel the individual in front of a mirror and do mouth care from behind, or even use a combination of hand over hand or some of the other activities, you may find that mirror mirror is really good for individuals who are more passive. Dentures can be tricky. The one thing we tell the people in our study, and I encourage other clinicians and providers, is to always see if the older adult will remove the dentures by him or herself first. The lower denture is very easy to remove, and to avoid frustration, we always ask the older adult to remove the lower denture first. Now, if that older adult has been removing the top denture first for 30 or 40 years, you're not going to get anywhere, but if they're having a problem with the top denture, going after the bottom denture first often reduces frustration. In order to break the seal and remove the upper denture, one technique is to have the older adult puff his or her cheeks to break the seal. Unfortunately, puffing does not always work. In that case, you may need to use your own fingers, and that's one of the reasons you take the lower denture out first. So if the elder inadvertently bites down, your fingers get caught between the gum and a biting surface versus two biting surfaces. But place your forefingers along the edge of the upper denture and your thumbs on the biting area toward the edge, and rock the denture gently back and forth, breaking the suction, and gently remove the upper denture. When trying to explain cheek puffing, by the way, this is where pantomime becomes really helpful. If the elder is completely unable to remove his dentures, you will have to do it, and first remove the lower dentures, and then again, using your thumb and forefingers, gently peel the lower lip back to expose the margin of the lower denture. Then use your thumbs to push on the lower border and your forefingers to grasp along the edge of the biting surface to pull the dentures out. For the upper dentures, and you can see the picture on the upper left-hand corner, gently place your forefingers along the edge of the upper denture and the thumbs on the biting area. Gently rock the denture, upper denture, back and forth to break suction, and then gently remove the upper denture. If the older adult tries to resist your removing of the denture, you can use the hand-over-hand technique, and in the pictures we show both techniques, either the elder's hand on top of yours or the other way around. Sometimes the older adult does not respond to any of these strategies and is absolutely refusing to receive mouth care. Should this occur and you cannot find any reason, such as pain or needing to go to the bathroom, then try the rescue strategy. Ask another caregiver to come in and rescue the elder from you, and this may promote cooperation with mouth care. Now, at this point, I would like to turn over the presentation to a valued colleague and friend, Dr. Elaine Amella, who will talk about dysphagia, which is a very common problem in persons with dementia.
Thank you very much. I would like to first thank NYU and Dr. Haber for inviting me, and then share with you my conflict of interest document. I will not be reflecting the views of my funders or the agencies I have previously performed work for. I hope to do three things in my short presentation: state reasons for the prevalence of dysphagia among people with dementia, identify people with dementia who are at high risk for dysphagia using psychometrically sound instruments, and finally, develop a plan of oral care for a person with dementia who has dysphagia. So, our first question really is, why worry about dementia and dysphagia? You probably haven't really thought of these two concepts being linked before. But before I answer that, I think we need to review some basic characteristics of dysphagia. Broadly defined as difficulty swallowing, I just first want to say that it's not a normal part of aging. There are some changes in the swallow related to muscle weakness, lack of hydration, problems with mastication or chewing related to bone and teeth health, but true dysphagia is not normal. And true dysphagia is penetration of fluids, food, or other foreign bodies onto the vocal cords and into the trachea because of either neurological or mechanical problems that are not expected. There are two basic components of swallowing. Some are under voluntary control of our nervous and musculoskeletal systems, and others are automatic. Therefore, with problems with either system can result in dysphagia. Swallowing impairments can affect our intake of food and fluids, our ability to protect our upper airway, and can change the effectiveness of the swallow itself. And the expert in this area is usually the speech and language pathologist or the speech therapist. They have the education and specialized training in this area, but truly dysphagia is a team effort and will require the help of RNs and advanced practice RNs, physicians, occupational therapists, the dietitian, certainly the dentist and dental hygienist. As we were talking about before, there are certainly issues with older adults who are both at home and in the nursing home requiring some assistance with meals and eating. This assistance can range from setup to queuing to preparing food to use of adaptive equipment and to actual physical assistance. That's why we really need to have a team approach when we talk about issues around meal times and eating and dysphagia. It is estimated by several sources that the majority of people with dementia have dysphagia related to deficits either in their mentation and other neurological changes as they affect the voluntary phase of swallowing or the non-voluntary phase, which is the esophageal phase. During the oral phase, food is mixed and chewed, and saliva is added, as Dr. Stein talked about, to form a soft consistency that's called a bolus. The tongue then moves the bolus toward the back of the mouth. Patients with impairment of the oral stage may have difficulty creating a seal around a fork or a spoon with their lips, chewing solid consistencies, forming chewed food into a bolus, or moving the bolus back in the mouth. During the pharyngeal phase, which is the second voluntary voluntary phase, and there are some automatic components of this too. The vocal folds close to keep the food and liquids from entering the airway. The larynx rises inside the neck, and the epiglottis moves to cover it, providing even more airway protection. If the pharyngeal phase is impaired, food or liquid can move into the throat before the automatic swallow is triggered, resulting in food or liquid touching the vocal folds or penetrating beyond the vocal folds and moving into the lung. Common symptoms include coughing before, during, or shortly after swallowing, a choking sensation, shortness of breath, changes in voice quality after swallowing, repeated pneumonia, weight loss, and weight loss. During the esophageal phase, we have totally non-voluntary organized movements of the bolus from the pharynx into the stomach. A disorganized swallow may lead to aspiration and ultimately pneumonia, which is the major cause of death in people with dementia. So after saying all that, what can we think about as dysphagia may be related to oral health? Certainly, we want to protect the upper airway. And as I said before, this really calls in the voluntary aspects of swallowing in the person with dementia. Oral health strategies include introducing fluids into the mouth and other objects such as toothpaste, toothbrush, swabs, water, or even, as Dr. Stein noted, other types of substances such as fluoride. Resistance to oral health, as Dr. Jambu mentioned, may make the person with dementia who already has dysphagia more at risk for aspiration. The gag reflexes and other hyperprotective systems may be triggered into with eventual aspiration with overreaction and penetration of fluids onto the vocal cords and into the trachea. So to meet objective 2, I'd like you all to consider persons with dementia who may be at risk for penetration of the vocal cords during oral care. Both behavior and compromised oral and pharyngeal stages of swallowing may put the person with dementia at risk. They may have poor oral hygiene and diseases from theirs or their families or their caregivers' inability to manage oral care per the other presenters. They can't hold secretions in their mouth during cleaning, and that would be certainly with the oral stage, their inability to essentially form a bolus of the food and protect and close the pharynx so that fluids stay within their mouth, or they may unsafely swallow secretions. Resistance, as Dr. Jablonski talked about, can lead to missed swallows, essentially a discoordination of already weak, poor, or inadequate swallow. And certainly for these kinds of patients, we need to refer them to a speech and language pathologist or a speech therapist. They will need further evaluation. 2 instruments that can be used either in people with mild cognitive impairment or in dementia and can be answered by the caregiver by proxy would be the E10 and the EdSet. Now, I have included copies of both of these, and actually, if you look at the reference slide, which is the last slide among my slides, they are listed there, so you could find the original document. The E10 is a 10-point swallowing instrument that discusses the individual's ability to swallow. Obviously, someone with moderate or late-stage dementia would not be able to answer these questions, and since some of the questions are so subjective, even the caregiver may be unable to answer them. However, several of them can be noticed in a person with dementia, And I know this is actually directly from the Nestle web page, but issues such as swallowing liquids takes extra effort, which is number 3. Swallowing solids takes extra effort. Swallowing pills takes extra effort. And when I swallow food, it sticks in my throat, and I cough when I eat. Could conceivably be answered by proxy with the caregiver answering those questions. Okay, just 1 minute here. I have to change the slides back. The other instrument that might be more helpful in a person with more advanced dementia is the Edinburgh Feeding in Dementia Scale by Roger Watson. Again, this is referenced in the last slide. And this itself asks us to examine both the level of assistance needed at meals and the level of dysfunction. The first several questions are really more related to issues that could be done by someone who is feeding themselves or requiring some feeding. The fourth question about leaving food on the plate at the end of the meal is I think, and I've talked with Dr. Watson about this question, some people throughout their life do leave food on their plate. So that may not be as appropriate for this group. And the fifth question, do they ever refuse to eat? I added these italics here because there's a question about people with dementia actively refusing eating. However, because they may not be aware of their right to refuse, it may be actually that, as was talked about before, they're resisting. So if we can translate this instrument to the act of giving someone oral care, it's really the questions that are in blue that seem to more relate to the act of oral care. Does the person turn his head away while being fed? Do they refuse to open his or her mouth? Do they spit out his or her food? Do they leave their mouth open, allowing food to fall out? And do they refuse to swallow? These kinds of actions, if they were translated to oral care, may actually mean that this person either cannot protect their airway or they are having some level of dysphagia that actually has not been addressed at this point, and thus they may need more help. Now, sorry, I have to make this go back down. So for our case study today, which is Objective 3, it actually builds on the work of Dr. Stein and Jablonski, and that we have here a 55-year-old male with early onset Alzheimer's disease who was admitted to a skilled nursing facility 8 months ago. He is dependent on all cares and quite impaired because his mini mental exam is less than 10, which would put him in the late stage. His EAT-10 score is 8, and his EdFed score is 14. He's lost less than 5 pounds in the last month, but certainly his weight is declining, as is his health, and he has poor oral health. The speech and language pathologist reports penetration of the vocal cords and probable dysphagia. He resists oral care except by his daughter, who can't always be there, and we need to come up with a plan of care. I would say that when we see a patient like this, whether it be in a nursing home or in the home, we need to think about more than what's happening right in front of our face. We need to think about the place where oral care is being given, the people who are doing it, and then primarily the person who is affected. We need to think about issues that Dr. Jablonski talked about. Is it a quiet place? Is it a place where we can focus on the oral care and when the person will be focused? I know Dr. Jablonski talked about distracting people during oral care, but for some individuals, distraction may actually cause them problems. They may start to move their head around, and attempts to open their mouth or to protect their airway may be blunted. We also want to make sure that the person with dementia is and their caregivers are not anxious about this process. One of the things we often find out in our work on mealtime and feeding people with dementia is that caregivers become very anxious. They want to hurry through the process, and I was not surprised that Dr. Stein noted that teeth were only being cared for 16 seconds. We know that in feeding people, most people in nursing homes are fed in between 5 and 10 minutes, whereas when people are fed at home, the family member will spend at least 45 minutes on the meal. So if the caregivers themselves cannot spend the time or they are rushing through the process, you might have more of a chance for failure of the oral hygiene itself, and you might actually trigger the responses that Dr. Jablonski talked about and exact some resistance from the person. And finally, in the person with dementia themselves, we need to look at what we can change. We definitely need a team approach. We need to think about involving the dentist, the hygienist, the speech and language pathologist if they're involving a plan of care, nursing, especially the advanced practice nurse, as well as the RN and LPN, and certainly educating the CNAs about not only the risk of poor oral care, but that this individual may indeed have problems with swallowing, which may be actually put them at risk for some sort of aspiration during oral care. We want to talk to the families and even think about involving the occupational therapist if there is some equipment that is better served at this point. I would ask you to look at the first article by Amela and Aslagi in the references that highlights a model of care that focuses on the place, the people, and the person. So now I'll turn the program back to Carrie for questions and answers.
Great, thank you very much. And I know we have about 1 minute until our program is scheduled to end, so we'll take one question here and we will pass along all of the other questions to our presenters for answering later on. Question that we will take today is the fluoride varnish something that can be applied in the hospital setting? How would I go about investigating this?
Well, I can attempt to answer that question. This is Dr. Stein, and I am a dentist, and so I also work as a public health dentist, and so we talk about fluoride varnish in a variety of settings, including children. But each state has their own rules about fluoride varnish. So the best way to find out about what the rules are for your state is to contact your board of dentistry for your state. So if you live in Ohio, it's the Ohio Board of Dentistry. Just Google that, get the phone number, and then call them and ask them what the rules are about application in your state.
Excellent. Thank you very much. And unfortunately, that is all the time we do have for questions today. But on behalf of Niche, I would like to thank each of you for joining us today and for your participation. Also, a very big thank you to our group of presenters for their excellent webinar today. When done with this webinar, please be sure to complete the evaluation located in the Niche Knowledge Center. The evaluation is necessary for you to receive your certificate. Also, if you have users additionally participating in the webinar who do not have accounts in the Knowledge Center and did not individually register for the webinar that need their CEU certificates, please send the name of all participants, including their email addresses, name of webinar, and name of the hospital to support@nicheprogram.org. This user will then be added to the Knowledge Center and then prompted to take the evaluation to obtain their certificate. Again, thank you all very much for joining us today. We hope you all have a great afternoon. You may now disconnect. Thank you very much.